Let's dive right into this explainer. Today, we are decoding the incredibly complex endocrine system. Forget the overwhelming textbook lists and the endless rote memorization. We're throwing that out the window. Instead, we're going to transform all these complex glandular diseases into a really simple, highly logical sequence of pattern recognition. We'll see exactly how the body tries to maintain that perfect metabolic balance. There is a master key for the entire human body that we're going to use today, and it basically boils down to this. Almost every disease we cover is simply a Goldilocks problem. It's always a matter of too much or too little. A hormone is either being overproduced, usually because of hyperplasia or a rogue neoplastic tumor, or it's being underproduced, simply because the gland itself is being destroyed. To test this out, we're going to take an anatomical descent straight down the body. First, the pituitary gland, second, the thyroid and parathyroid, third, diabetes and the pancreas, and fourth, the adrenals and MEN syndromes. Starting right at the top, section 1, the pituitary gland. So, when things go wrong in the pituitary, which, is the true master gland of the system, it's usually driven by benign tumors called adenomas. And prolactinomas are by far the most common, making up about 30% of cases. But this leads to a fascinating anatomical trap known as the stalk effect. Think of dopamine as the brakes. Normally, the brain sends dopamine down the pituitary stalk to slam the brakes on prolactin production. But if a non-secreting tumor grows and physically compresses that stalk, well, the brakes are cut. So a tumor that doesn't even produce prolactin causes your prolactin levels to absolutely spike just by blocking that critical dopamine signal. On the flip side, we have underproduction. And the thing is, the pituitary is incredibly resilient. It's essentially a building with a massive, heavy-duty backup generator. You literally have to lose a staggering 75% of the gland before you even notice a hormone deficiency. That kind of massive destruction usually only happens when a growing tumor just completely crushes the healthy tissue, or from severe blood loss after childbirth, which you might recognize as Sheehan syndrome. Let's apply our master key to the posterior pituitary. If it starts underproducing antidiuretic hormone, ADH, you are going to lose excessive amounts of water. And this turns you into a medical detective. You've got a patient with intense, unquenchable thirst. Is it caused by primary polydipsia, where they're just compulsively drinking way too much water? Or is it diabetes insipidus, where their body physically cannot hold on to the water no matter what? We can actually solve this mystery perfectly using a water deprivation test followed by a dose of synthetic ADH. If we give the ADH and the patient's urine suddenly concentrates and goes back to normal, boom, it's central diabetes insipidus. The brain just wasn't making the hormone. But if nothing changes at all, it's nephrogenic. The brain is doing its job fine, but the kidneys are completely ignoring the signal. Moving down into the neck, section 2, thyroid and parathyroid. We have a classic paired discriminator here. Graves' disease represents our too much state. It's an autoimmune condition where antibodies actually overstimulate the gland, ramping up the metabolism, causing those distinct bulging eyes, and creating that thick, waxy skin on the shins called pretibial myxedema. Conversely, Hashimoto's is our too little state. Same gland, but here the autoimmune response is actively destroying the tissue with a swarm of immune cells, leaving the patient with sluggish hypothyroidism. Now, if you were ever looking at thyroid neoplasms under a microscope, there is an absolute golden rule for separating the benign from the highly malignant. Papillary and follicular carcinomas are distinguished right away by their nuclear features. But actually, scratch that. The real trick is telling a benign follicular adenoma from a malignant follicular carcinoma. For that, you have to look at the borders. Capsular or blood vessel invasion is your definitive proof. If it breaks through that capsule, there's no question it's malignant. Let's look right next door at the parathyroid. You can instantly distinguish a gland tumor from renal failure just by checking which direction the calcium levels are moving. In primary hyperparathyroidism, which is usually a rogue tumor, the excess hormone abnormally drives calcium way up. But in secondary hyperparathyroidism, usually from failing kidneys, the body is losing calcium. The parathyroid itself is perfectly healthy, but it's frantically pumping out hormone in a desperate attempt to fix that low calcium level. Continuing our descent into the abdomen, section 3, diabetes and the pancreas. Notice how perfectly both types of diabetes fit into our overarching master key. Type 1 is entirely a story of total destruction and underproduction. An autoimmune attack just completely wipes out the insulin-producing beta cells, leaving zero insulin and a very high risk of diabetic ketoacidosis. Type 2, on the other hand, which makes up a massive 80 to 90% of all cases, is a failure of the signal itself. The body is making insulin, but peripheral resistance means the cellular locks are jammed and just won't open. So how do we definitively call it? There are 4 rigid, undeniable diagnostic thresholds you absolutely need to know to identify when the pancreas has lost control. Whether it's a fasting glucose over 126 or a random glucose over 200 accompanied by symptoms like severe thirst, these numbers give us an objective line in the sand. And catching this early is absolutely crucial. Why? Because unchecked blood sugar physically destroys blood vessels over time. The excess sugar essentially gunks up the microvasculature. We call these advanced glycosylation end products, but really, it's just slow systemic destruction. It's exactly why diabetes is the #1 cause of end-stage kidney disease, adult-onset blindness, and non-traumatic lower extremity amputations. Making our final stop, Section 4, the adrenal gland and MEN syndromes. When we look at congenital adrenal hyperplasia, a staggering 95% of all cases come down to just one single specific error, an enzyme deficiency called 21-hydroxylase. This one roadblock completely halts the production of cortisol and aldosterone. So the brain panics. It aggressively stimulates the adrenal gland to make more. But because of the block, the gland inadvertently shunts all its raw materials into producing a huge excess of sex hormones instead. Now, when the adrenal glands fail entirely, like in Addison's disease, we're back to being medical detectives. We have to ask, is the failure happening in the gland itself, or is the problem up above in the pituitary? It's our two little master key applied directly to the adrenals. The ACTH stimulation test splits this perfectly. In primary failure, the adrenal gland is destroyed, so the pituitary is just screaming for attention by pumping out massive amounts of ACTH. And here's the wild part. Because ACTH shares a precursor molecule with melanin, this huge spike in ACTH actually causes the patient's skin to hyperpigment. In secondary failure, the pituitary itself is broken, so ACTH is low, and you get absolutely no skin color change. Wrapping up our specific conditions with multiple endocrine neoplasia, we can easily distinguish type 2A from 2B based solely on the parathyroid and the patient's connective tissue. Both syndromes involve thyroid and adrenal tumors, for sure, but MEN2A features parathyroid overgrowth, while MEN2B completely spares the parathyroid. Instead, 2B uniquely presents with a marfanoid body habitus, meaning these patients have a distinctively tall, thin frame with very long limbs. Finally, Section 5, the endocrine framework. Let's pull it all together by abandoning rote memorization and leaning completely into this master key framework. You can logically reconstruct almost any endocrine disease, even under pressure. It always comes down to overproduction or underproduction. It's driven by runaway growth or physical destruction. And by isolating those paired discriminators, like primary versus secondary, the diagnosis practically reveals itself to you. I'll leave you with this provocative thought about the future of medicine. If we can so perfectly map out these metabolic signaling pathways, these biological thermostats, what happens when we move beyond just treating the disease? What happens when we finally learn to entirely reprogram those temperature settings? It's a wild thought. Thank you so much for joining me on this explainer. Keep asking those big questions, and I'll see you next time.